All right. As more people continue to trickle in, I'll just take a moment to introduce myself. I'm Brianna Botsford. My pronouns are she, her, and I'm honored to be here tonight representing the Lois Hole Hospital Women's Society. Since our founding in 2017, the Women's Society has proudly raised over $1 million to support the Lois Hole Hospital for Women, which is Alberta's only dedicated women's hospital, providing specialized care for women in all ages and stages of life. We're so glad to have you here with us tonight as we continue raising both awareness and funds for this vital cause, none of which would be possible without supporters like you. Between us as part of that work, this series was created to offer a safe, inclusive space to talk about topics in women's health that are too often overlooked, whether it's reproductive, mental health, menopause, or tonight's topic, which is a little bit of both. Thank you for showing up, staying curious, and participating respectfully. And of course, a huge heartfelt thank you and so much gratitude to Alberta Blue Cross for their generous support as our series sponsor. And your commitment allows us to host this informative series and make a meaningful impact in our community. So thank you, Alberta Blue Cross. We're so glad to have everyone with us here tonight. It's a large group. And to help you get the most out of the evening, I'm going to pass this over to Ijoma from the Royal Alex Hospital Foundation, who's going to walk us through a few housekeeping notes before we get rolling.
Thank you, Brianna. Just before we dive in tonight, I just want to share a couple housekeeping tips. Please type your questions for our speaker in the Q&A box. They will be addressed during the Q&A anonymously. Anything posted in the chat box will be public. Before we jump into the questions, also a quick reminder that this isn't a space for personal medical advice, so we would like to keep the questions focused on your experience and the topics that we're talking about today. We're using Zoom webinar, so only our panelists are visible, and this webinar can also do a live transcript, so you can enable that on your computer if you would like. Each lecture is recorded and available on the Women's Society YouTube channel afterwards, and after the event, please remember to fill out our feedback survey for a chance to win a $25 gift card courtesy of Alberta Blue Cross. Thank you, and I hope you find this evening's session valuable. Now, a quick word from Elizabeth from our presenting sponsor, Alberta Blue Cross.
Thank you very much. My name is Elizabeth Hamill, and I'm here from Alberta Blue Cross. My pronouns are she, her, and it's a pleasure to be here tonight. At Alberta Blue Cross, we value the importance of talking about women's health. Topics like tonight's on heart health and hormones really highlight how the factors we didn't even consider can play such a vital role in heart health for all ages. Having these conversations can help women gain a deeper understanding of the role ovaries play beyond reproduction and could save lives. Knowledge really is power when it comes to our health, and as always, we are very proud to be sponsoring this series. Before we begin our lecture, we'd like to share our gratitude and appreciation for the land from which we all benefit and look to the guidance of Indigenous community leader Connie Calahoo Stonehouse to lead us through the land acknowledgement.
Tanse, greetings. We gather here in Treaty 6 territory, where the Blackfoot, the Cree, the Dene, the Nakota Sioux, the Anishinaabe, Saulteaux, the Métis, and the Iroquois peoples, which is my family, call this our homelands. During my grandparents' lifetimes, this land was not only their home, but their hospital and their healthcare system. Their health and well-being were connected to each other and to the land. The berries we picked, our medicines, sweetgrass, sage, bare root, and many others were all harvested in the rhythm of the seasons. The water they would drink was from the lakes and the rivers, where they would also fish to feed our families. We must not forget how important our connection to the land is. For the food we grow, the water we drink, not just for ourselves, but for future generations. I'm here to remind you, we still have much work to do in our relationship with the land, the water, and each other. As Treaty 6 relatives, we must remember what our ancestors agreed to. As long as the sun shines, the grass grows, and the rivers flow, we will look after each other, the land, the water, and all the beings that we share these lands with. Hi, hi.
Now, I would like to introduce this evening's speaker, Colleen Norris. Dr. Norris is a professor in the Faculty of Nursing at the University of Alberta, registered nurse, and holds the Cabazan Chair in Women's Health Research for the Alberta Women's Health Foundation. She's also a well-respected expert in cardiovascular health. Additionally, Dr. Norris is leading part of the Women's Heart Health Research Collaborative, which partners with the CK Hughes Heart Center, the Lois Hole Hospital for Women, and the Alberta Women's Health Foundation to improve women's cardiovascular care. Dr. Norris is currently developing 2 pioneering clinics, a nurse practitioner-led research clinic advancing women's cardiovascular health, and a publicly funded specialized post-reproductive health clinic, each the first of its kind and designed to set new standards for women's healthcare. Dr. Norris focuses on how sex, gender, and hormones impact women's health throughout their entire life cycle, from perimenopause to postmenopause. Her research explores how these factors influence conditions like cardiovascular disease and other health concerns. Dr. Norris's groundbreaking work continues to shine a spotlight on the complexities of women's health and aims to create a more holistic and inclusive approach to clinical practice and policy. Welcome, Colleen.
Thank you so much. I will, share my slide. Always that delay. I am so grateful to be back here talking at the Between Us. And, I remember meeting Brianna at the celebration of the Lois Hole Women's Hospital Society at the Royal Glenora and just being overwhelmed at what an amazing job women are doing for women in Alberta through the Lois Hole Women's Hospital Society, and especially excited about talking with this group because this is the age that we really need to make changes. And so I'm going to talk tonight about cycles to cessation, and the power to protect her heart or your heart starts right now. I also just wanted to acknowledge the land that we're on. This is a picture of a medicine wheel taken from the Indigenous Corporate Training website. And I was shocked to find out that, on the website, they write they've identified 46 medicine wheels like this one in Alberta, and it constitutes about 66% of all the medicine wheels in Canada. So specifically, I think often of Indigenous medicine women who lived and live on the lands across Alberta and the vital role that they play in their communities, serving as healers and herbalists and spiritual guides. And we have a lot to learn from them. They utilize traditional knowledge passed down through generations to treat various ailments using natural remedies, including plants and roots and other natural substances. Their practices are deeply connected to the cultural, spiritual beliefs of their communities and emphasize a holistic approach that considers the physical, emotional, spiritual well-being of individuals. And from a nurse's perspective, this really resonates with us. So I'm grateful to live and work on the land that they continue to protect for us. So I'm going to start with this basic sophisticated feedback loop that even I didn't remember from my undergraduate nursing classes. You have to think of your ovaries as full gumball machines. And you can see that when you're in utero and as a female child, you will have 6 to 7 million follicles. At birth, you have 1 to 2 million. By puberty, you're down to about 300 to 500,000. And the follicles are very important for your estrogen level. So I'm just going to go quickly through this. The hypothalamus in the brain releases what we call gonadotropin-releasing hormone to the pituitary glands, and it stimulates the release of follicle-stimulating hormone. And follicle-stimulating hormone travels to the ovaries to induce the growth of follicles. And 20 or so are released a month, and they all try and grow at the same time. But the growth also increases the amount of estrogen that you have, and it starts to grow the uterine lining. And that's why it's called the follicular phase. And it triggers the pituitary to release what's called luteinizing hormone, or LH. And the LH is the trigger for ovulation, and one follicle will be released. The follicle then reforms and becomes what's called the corpus luteum, and that stimulates the luteinizing hormone to release pulses of progesterone, and that's called the luteal phase. If you're not pregnant, that corpus luteum lives for about 2 weeks and then dies, which drops off the progesterone level and is a signal to the uterus to bleed and shed the lining. The issue that applies to women's heart health and actually brain health and kidney health is that we have completely ignored how any disruption in this process has the potential to influence our vascular system. And our vascular system is all your blood vessels and your heart. And it includes, now we always think of the heart and the brain together because the blood vessels attach them together. In the past, famine or being malnourished or war times led to the ovaries not producing estrogen. And they signaled to the brain not to send out the gonadotropin hormone because the brain was basically deciding this body is not able to carry a pregnancy. And it was not a good time to be pregnant. And it shuts off the release of the follicle stimulating hormone. So the statement that I'm now really pushing is that the ovaries are actually the architects of a woman's health, which means the ovaries do far more than control reproduction. They are the central regulators or designers of multiple systems in the female bodies across the lifespan. And here's what that implies. The ovaries produce estrogen and progesterone that orchestrate the development and function of the cardiovascular, the skeletal, your bones, the neurological, your brain, your immune, and your metabolic systems. And these hormones influence your arterial elasticity in your blood vessels, your lipid metabolism, your bone density, how strong they are, your mood, your cognition, and even immune resilience. Ovarian hormones modulate your health from puberty to menopause. And their gradual decline, especially the loss of estrogen as you're going through the menopausal transition, actually reshapes your cardiovascular risks. And it accelerates what we call vascular stiffness. It increases insulin resistance and contributes to osteoporosis or bone breakdown, and also cognitive decline. Because estrogen receptors exist throughout the body, the ovaries actually serve as the master control hub, coordinating communication across all the organs. When ovarian function changes for one reason or another, the entire physiological architecture adapts, and sometimes it maladapts, leading to increased chronic disease risk. From a clinical and policy relevance, recognizing the ovaries as the architects of women's health reframes it from this narrow focus on fertility to a lifelong systemic issue. And it underscores the need for clinicians and women themselves to have early hormonal monitoring and research investment into ovarian aging. In essence, this paradigm shift encapsulates that the ovaries are not simply reproductive organs. They're the blueprint designers of a woman's overall health. So let's talk a little bit about estrogen. Please meet the hormone woman, and this is from a Seattle website on Women Living Better, and it's a group that does research in this area, and they created this to identify that the estrogen, which is produced in the ovaries and in the adrenal glands and some fat tissue, but there are 400 estrogen receptors in your body. These receptor sites are included in the brain, the muscles, the gut, the uterus, the ovaries, the vagina, the breasts, the eyes, the heart, the lungs, and blood vessels. And it does many things, but you think mainly of estrogen as a growth promoter. Progesterone is found in exactly the same 400 sites, and it's made in the ovaries while a woman is still ovulating. After menopause, it's made in the adrenal glands in smaller quantity, and progesterone receptors are found throughout the entire body in the same places. And while estrogen promotes growth, progesterone actually promotes calming. The other thing we've identified here is the ebb and flow of the 4 hormones that I've talked about: follicle stimulating, luteinizing hormone, estrogen, and progesterone. And you can see the reliable cyclability that happens after puberty into your late 30s. The pattern in the middle is what happens as your estrogen levels are starting to decrease because your follicles aren't producing as much estrogen anymore. And then after menopause, by the way, menopause is defined as one day in your life, and that's 12 months without a menstrual cycle. And then you're either pre-menopause or post-menopause. So you'll hear me referring to this as either perimenopause or the menopausal transition. But you can see how erratic the estrogen and progesterones are in those middle menopause transition phase. The other thing that I wanted to mention is this: in 2001, a group got together called the Staging Reproductive Aging Workshop, and they created this straw staging, which established criteria, and they included a stage called the late reproductive stage. The late reproductive stage happens in your late 30s. And what is included in the green box is that late reproductive stage through perimenopause until your menopause, which in Canada, the average age of that one day of menopause is 51 years of age. The importance here is understanding that the path of reproductive aging is really important to recognize the effect of the collection of other potential challenges that are happening at the same time as this. So when I thought about this, the late 30s to say 55 years of age on average, it is actually the most challenging, stressful time of a woman's life, women's midlife. And all of these stresses are occurring concurrently. So gender factors and health concerns and trying to ramp up your career and taking care of maybe young children or elder parents, or balancing work and personal life. There's deaths, there's frustrated goals, there's financial worries, especially in these times. These are all happening at the same time that you have biological changes that are happening as far as your estrogen and progesterone levels are concerned. This is called a radiograph, and it was identifying some of the symptoms that were reported in the late reproductive stage. And what was happening is women were going into the clinicians and saying, something's wrong, I don't feel like myself. And it ended up that the group in Seattle labeled it, I don't feel like myself. And they identified these symptoms, the ones that go right to the edge, like fatigue and irritability and low feelings, or feeling overwhelmed and coping, and anxiety, are the symptoms that we have completely neglected that are suggesting that your estrogen levels are starting to change. And a number of you have probably heard this, but when I was 42, I went into the physician, my clinician, and said, I think I'm going to kill somebody. I was so incredibly irritable and angry all the time, and it wasn't me, and I couldn't figure out what was going on. And in fact, I remember waiting for my kids outside the 7-Eleven that was near our house at those times, and my little son looking at me like, oh my God, she's going to blow. And so that's why I went into the physician, and the physician said to me, has your cycle changed? I said, no, I'm 42. And said to me, it must be stress, and maybe we can try an antidepressant. But the sad thing is that was a long time ago, and that's what's still happening today. And that's why we're trying to create this awareness to women about what's going on in their bodies. So we've known for a while that estrogen, endogenous estrogen, that's the estrogen that your body makes, does shape a woman's health. But somehow it's got lost in specialized care. So while I'm focusing on estrogen, progesterone is far more than a hormone that simply regulates building and shedding the uterine line. It is also central to biological signals in the women's health, and it modulates your neuroendocrines in your brain, your vascular health, and your immune health. But across the lifetime, estrogen and progesterone are important, and they both have systemic hormone multi-organ effects. This is an interesting diagram that I pulled out looking specifically at estriadol, which is a type of estrogen we're talking about, and progesterone. And you can see from childhood through to teens and through the reproductive years how it keeps going up and going down as you cycle through your periods. But as you can see in perimenopause, very dramatic drop in progesterone, and estrogen is making its way down in a very erratic way. By age 40, your progesterone levels can plummet by as much as 75%, and estrogen has declined by about 35%. This is in your 40s. And it's a 5 alarm fire for your nervous system because progesterone performs 150 vital functions. But its most important role is your brain's primary calming agent. It works by regulating your GABA receptors and the neurotransmitters that tell your brain to relax. So when it disappears, your brain stress hormone, cortisol, spikes as much as 400%. And I'm going to talk more about cortisol coming up. But your nervous system gets stuck in this 24/7 fight or flight mode because progesterone has gone down, you don't have that calming agent, cortisol starts and tells you that there's something wrong, and you get this anxious feeling and you're in fight or flight. And the article I was reading said, suddenly your husband's chewing sounds sound like a jackhammer, or you finding a parking spot is like a life or death mission. And you're constantly on edge because your brain is missing the one signal that is telling it it's okay. But we're going to go back to estrogen. And I put this quote up because Estelle Ramsey, who was an American endocrinologist and physiologist and feminist who made significant contributions to the study of hormones, but she is best known for challenging sexist claims about biological differences between men and women, particularly in response to a 1970s remark by a politician who suggested that women's hormones make them unfit for leadership and disease resistance. And I think that war on women's participation in society due to ignorance of the sex hormones continues today. And we see it reflected in every aspect of social media constantly. And I know myself, I found through the menopausal transition that I'd get comments back of you're being emotional and not recognizing myself that there was a biological reason for what was going on and how I was responding. So I'm going to get on my soapbox here just quickly, and then we'll move on. But the marginalization of women's participation in society has long been intertwined, I believe, with a profound misunderstanding and misrepresentation of female body's sex hormones. And that dynamic absolutely persists today. Across social media, political discourse, public commentary, we continue to see women's biology reduced to caricatures and their hormonal physiology framed as weakness or instability or limitations. Efforts to regulate or control women's fertility are not simply about reproduction. They're about controlling women's health autonomy and their full participation in civic and professional lives. So belittling language, dismissive narratives, and attempts to silence women reinforce these inequities, even when framed as humor or a casual comment. So scientific literacy is a powerful countermeasure. When we understand what estrogen and progesterone do in the brain and the vasculature, in the immune system, we can dismantle these myths. And education actually transforms hormones from political talking points into biological realities. So I'm mentioning this because I even think the whole episode of the U.S. women's hockey team not getting recognized for their success and actually a laugh and being invited as an end note, it continues this whole business about, well, but they're women. So more specifically, I want to talk about the relationship between estrogen of the heart. It is February's Heart Month, and so I'm going to focus more on the heart as we move along, but actually, estrogen does so many things for your blood vessels and for your heart. It has antioxidative effects, and oxidative stress in your body is like rusting on the inside when a harmful free radicals build up. And normally antioxidants act like a protective coating, but when they're overwhelmed, damage to cells occurs. Estrogen blocks the signal that attracts harmful immune cells and platelets, and creates the inflammatory process. It keeps the blood vessels stretchy and pliable. It increases the good cholesterol and it decreases bad cholesterol that clogs and damages your blood vessels the way grease clogs a pipe. Your vessels are making, with estrogen, it makes it easier for the blood to flow, and it decreases the risk of heart issues. Estrogen increases nitric oxide and prostaglandin, which relaxes the blood vessels and improves your blood flow as well. It controls how blood vessels grow and can prevent the plaque buildup. Estrogen is also a matter of the brain. It provides neuroprotection. It has neurotransmitter regulation, so it stabilizes your mood. It prevents amyloid and neurodegeneration prevention. And you might have heard of amyloid beta's accumulation, which is what we have identified as being responsible for Alzheimer's disease and definitely Alzheimer's disease risk. It promotes synaptic plasticity, which means it promotes your brain being able to change, and particularly in the prefrontal cortex. So it helps with your memory and your attention and your processing speed. It helps protect the blood vessels in the brain, just as it does for the heart, and it regulates your mood and emotions. Estrogen is also vital to our bones. It maintains bone density and strength. It inhibits bone breakdown and it stimulates bone formation. So the minute that estrogen is cut off, we start to have bone breakdown and we don't have new bones growing. And it protects this trabecular spongy bone, particularly the important area that's rich in your bones, which is spine, hips, and wrists. And hip fractures are one of the most common causes of debilitation and actually death in women. Older women. After estrogen declines, bone reabsorption exceeds bone formation, and it leads to accelerated loss. So that is why women will lose, 3 or 4 inches as they hit menopause, after they've hit menopause, because of this bone loss. So just to reiterate, for the cardiovascular system, it's responsible for vasodilation, anti-inflammatory, vascular, lipid, antioxidants, all of these things. And it's imperative that we understand that it's related to your heart disease and how your heart functions. Progesterone, I just wanted to emphasize the influence of mood and emotional well-being, but also the metabolic process and your appetite, which changes as soon as your progesterone starts dropping. It can promote better sleep patterns, and it helps regulate your immune responses. What do we do today that are the causes of estrogen and progesterone imbalance? Well, the chief of these is stress. And we need to talk about stress because it's increasingly important to note that the effects of hormone changes, particularly mood changes and levels of anxiety and cognitive changes, can be difficult to differentiate from those concurrent life stressors that are going on in your life, like caring for children or managing paid or unpaid employment and conflicting life roles. The late reproductive stage, I will repeat, and perimenopausal is considered the most stressful time of a woman's life. And it's been commonly reported by women in midlife that the problem is trying to manage these multiple responsibilities that are going on. The study from the Seattle Midlife Women's Health Group identified that participants found themselves searching for balance with multiple co-occurring stress. And when asked in the past 15 years, what was the most challenging thing for you? And it was commonly reported that the challenge for midlife women was coping with all of these stressors that are happening. And I'm just going to spend a little bit more time on stress because I'd like you to note the red flag here. And that's because your body and your brain prioritize the production of cortisol over estrogen, particularly in high stress milieus. High cortisol levels associated with chronic stress can impact the level of estrogen and progesterone, and elevated cortisol leads to hormonal imbalances by inhibiting the production of these sex hormones. And so it results in lower levels of estrogens, which contribute to symptoms like irregular cycles, mood swings, and sleep disturbances in particular. Additionally, high cortisol interferes interferes with normal functioning of the ovaries and the adrenal gland. And in addition, high stress levels or chronic stress level create this cascade of physiological effects that stress put on a woman's heart and put it at risk. Because stress increases your systemic inflammation and it leads to inflammatory cytokines coming along, and chronic stress alters your white blood cell level, which is responsible for getting rid of viruses, etc., when they're in your body. The important thing here is that at the same time that a woman's estrogen levels and progesterone are starting to decrease, they are in this high stressful level. And when you are in chronic stress or in fight or flight, your body, even though you may say, I'm sitting down and I'm relaxing and I'm fine right now, your body is still running at full alert, because in the old days, the fight or flight was getting your body ready for you to either fight that tiger or to flee. And so it's cortisol that helps do that. And it does things like it shuts off or lowers the blood system to your stomach, so you don't need to use it for digesting. It increases the blood volume to your heart and your brain so you can think on your feet. And so you're in this high anxiety level that you are operating in, even when you're thinking you're relaxed. And I have been to physicians who have said that, you know, you have too much stress at home and you've got to get a handle on it. And I'm starting to think that's malpractice. We need to identify, is it estrogen that might be setting you up here? Because it's this double whammy that's happening. Cortisol is tamping down its production of follicle stimulating, so you produce more estrogen, and your estrogen has already started to wane off. So one of the things that we're really looking at in our studies that we're doing is how to turn that off, even for 10 minutes a day. And there's all sorts of non-pharmacological ways of dealing with that stress, but it's recognizing what's going on in the first place. The other things that I want to briefly touch upon is other causes of estrogen and progesterone imbalance. And one of them is the birth control pill or an IUD that has a drug-eluting IUD. Estrogen used in most birth control pills is a synthetic form of estrogen, and it's referred to ethinyl estradiol. But while it mimics the effects of the natural estrogen produced in the ovaries, its chemical structure differs slightly, which can affect how it's metabolized in the bodies. And actually, birth control pills are fooling your brain into not producing follicle-stimulating hormone and the luteinizing hormone, into thinking your body is pregnant. And that's what birth control is doing. And the suppression of follicle stimulating is a key mechanism by which birth control pills regulate your menstrual cycle, or even prevent it and prevent a pregnancy. So it's important to pay attention to that, because women have said, but I'm on birth control and I have estrogen in that. And it's not the same as your own endogenous estrogen. Moving on, in vitro fertilization causes hormone imbalances due to the introduction of synthetic hormones like gonadotropins that stimulate the ovaries to produce multiple eggs. And this leads to fluctuation in hormone levels as the body responds to this external hormone. Additionally, the rapid development of lots of follicles overwhelms the body's regulatory system, leading to an imbalance of estrogen and progesterone. And more importantly, Dr. Natalie Crawford, a infertility specialist, reports that regardless of the reason the brain shuts off the production of follicle-stimulating and luteinizing hormone, and ultimately estrogen, it takes years after IVF to reprogram your brain to start the process related to the production of estrogens and progesterone. You may have heard, and you may know, that excessive weight loss, dieting can cause hormonal imbalances. And this is actually where our team got started on this, is that my PhD student, not my PhD, our wonderful PhD student, Nicole Tague, who's working with our group, brought me a study, and it was on postmenopausal women. And both groups of women were exercised, and one group got estrogen. But the results were that there was no value to the exercise unless you had the estrogen with it. And at the same time, I was part of the Canadian Women's Heart Health Alliance. And this is a group across Canada, anyone can join, that's involved in women's heart health. And so we have women with lived experience that are on our teams. And they were coming and saying, but I was a long distance runner, I was an athlete. And what we started to think about those postmenopausal women and the women that were showing up with this early heart disease was the one thing they had in common was amenorrhea, what we call amenorrhea. So amenorrhea is defined as 3 months or more without a period. And it's often caused by extreme dieting, extreme weight loss, and excessive exercise, and also obesity. And the interesting thing is that what happens in amenorrhea is that you do not have a period and your brain has shut off the follicle stimulating hormone and luteinizing hormone. So you are not producing estrogen. And I just identified how important estrogen is for all of your blood vessels and your brain and your bones. And so what's happening when athletes are amenorrheic might be doing damage to the inside of their vessels. We actually don't know that. And so Nicole has gone on to look at, it's a really interesting study. She did surveyed 400 women who had had a baby and asked about their athletic, how much they did as far as their athletic information was concerned, and then asked them if they had amenorrhea. And there were women who had had amenorrhea for over 10 years. No period for over 10 years. And all of them consistently say they went to the clinician and the clinician would respond, are you trying to get pregnant? And they'd say, no, then don't worry about it. And we're saying, I think we need to start worrying about it. So this is what the Canadian Women's Heart Health Alliance, we developed an atlas and it's open to anybody. It's called the Canadian Women's Heart Health Alliance Atlas and it's available online. But it identifies all of the things that are involved in a woman's life that we know are associated with early cardiovascular disease. And that includes a period before you're 11 years old, menstrual cycle irregularities throughout your whole menstrual cycle, polycystic ovarian syndrome, if you had depression as a, in your late teens and early 20s. Whoops, I'm going to go back one. Contraceptive use, autoimmune diseases, all of these are related to early cardiovascular disease or premature cardiovascular disease in women. And what these all have in common is a lack of estrogen in one way or another. And that's when it really hit me when I started to investigate this. The other thing is I do what we call sex and gender science, and we collect what we call gendered factors. And that includes gender identity, but it also includes things like gender relations and gender roles and gender, institutionalized gender, how you're expected to act in the institution that you're in. And we found that these factors also influence worse outcome for women's heart health. So the amount of parenting and housework we do, and there's this idea that maybe it's evening out, but it actually isn't. At the last study that I found, who's doing more and when, and gender, parenting, and housework trajectories. We have identified that intimate partner violence is associated with early heart disease. And again, it makes sense because of the stress angle, I'm sure. Childhood adverse events that include, sexual abuse or physical abuse or mental abuse, that has been found to be associated with early heart disease. Again, I think the mechanism is the stress and a lack of estrogen. Gender roles and gender relations and gender identity. All of those are associated with early heart disease, along with the biological factors that I mentioned earlier. So back to the heart and why it matters. Well, in 2018, I was also involved in this report done by the Heart and Stroke called Misunderstood, and that identified that women with heart disease are understudied, underdiagnosed, undertreated, undersupported, underaware. And I really thought that once we got this information out there, we'd figure it out because, it's like 78% of women were going to the emergency department with symptoms of heart disease, heart-related disease, and were being turned away. In Alberta alone, our study identified 30,000 women a year who went to the emergency department, were discharged home, and came back in within 30 days having had a heart attack. And so we were missing what's going on with women. And we would say, well, we present differently. And There was a word used, atypical heart disease, but it isn't that. I am convinced women's heart disease is completely different than men's heart disease during the perimenopausal phase. After menopause and postmenopause, it does look more similar to men's heart disease. And 2/3 of heart disease clinical research focuses on men. I think I've mentioned this before, but we've looked at studies for the guidelines on how to treat people who have what's called ST elevation myocardial infarction, or a type of heart attack. And I looked at our team looked at the studies that were used to create those guidelines. And there were studies in those guidelines that had no women in them. And so it may work for women, what drugs we use, etc., but we actually don't know that for sure. And originally it was because of these safety concerns. And they said, oh, the hormonal fluctuations, we can't get good data. And that's even basic scientists were saying that about using female mice. They just used the male mice and they knew what they could prove and move on from there. Then there's this myth of lack of participation. Women don't like participating in research. And I say it's a myth because I've had so many experiences where it's been identified that we do not make it possible for women to participate in research. And that's what's going on. And so we've been looking at this from every angle that we can. And I have a really good example of this. There was a clinic that was being offered for the Royal Alec Hospital, and it was a clinic for older mothers who had preeclampsia. And in the hospital, they were asked to join the clinic, and they would get a nutritionist and a physiotherapist and a doctor and a nurse practitioner and a pharmacist. Everybody was there to figure out how to make sure that your preeclampsia it's called a vascular complication of pregnancy, which means it has to do with your blood vessels. So how do we prevent you from developing heart disease? And I was shadowing the clinic one day, and the biggest problem they had with this clinic is everyone's sitting there waiting, and there were no shows. And while I was there, the phone rang, and it was a woman on the phone that said, I've been driving around this effing parking lot for 2 hours, and you can hear her newborn screaming in the back and saying, I'm going home. And it really hit me that we don't make it possible for women to participate because of the way their lives are handled or scheduled. And we've been trying things like creating where you pick your own appointment, or even for research, putting out a list of days that we're going to be doing it, rather than telling you need to come in Wednesday so we can measure your arterial stiffness. We say, here are the times we'll be here, what one works for you. So we're really trying to do that. But every time we've put out a survey as far as our research is concerned, we have 400 or 500 women that fill it in without a problem. I don't think it's a lack of participation. It's unable to participate. These are the female predominant types of heart disease, and it's called coronary microvascular dysfunction, coronary vasospasm, spontaneous coronary artery disease, and a thing called ANOCA. And I put this picture up because you could see that the main coronary arteries, the big ones that are here on top, I don't know if you can see my mouse, but the big ones that sit on top are called your coronary arteries. And when you go in for an angiogram or a heart test, it looks at those coronary arteries. But more than 40% of women who go in for their angiogram have no plaque buildup in their coronary arteries. And my colleague, Shannon Scott, who has microvascular dysfunction, ended up being told your vessels are pristine. And what happened up until recently is the woman would be told it's not your heart. But we've now discovered that it's all of these vessels underneath that have been irritated and are not working properly. And I do think that has to do with the lack of estrogen at some time in that woman's life. Coronary vasospasm are when these big arteries, I'll go back. When the big arteries, sorry, wrong way. When the big arteries actually go into spasm. And what's the problem with that is they spasm and it causes incredible chest pain and cuts off the oxygen to the heart and can even cause a heart attack. But when you come in, they've opened up again. And so we our tests cannot identify that was happening and that your vessel was going into spasm. Spontaneous coronary artery dissection, or called a SCAD, is one of those coronary arteries I think of my mom before she died, and her skin was so fragile. And if you touched her with your thumbnail, it would just split the skin. And that's what's happening in sudden coronary artery dissection. The vessel just dissects, which would again suggest that there's something wrong with that vessel. It's not healthy. And it's the epithelium that the inside of the vessel that the estrogen really feeds and bathes. And so if you don't have that estrogen, it stands to reason they're going to get hardened and not be as pliable as they would be. Anoka and Manoka are called ischemia with no obstructive coronary arteries disease, or a myocardial infarction with no obstructive coronary artery disease. These two are likely caused by these other three, but those are the female predominant heart diseases. The other thing we need to reflect on is the symptoms that women present with. They are not atypical. They're very typical to women, and we've identified that. There will be some kind of chest pain, pressure, or discomfort that women report, but they'll talk about it being burning. It's not the elephant sitting on my chest. It's just like a squishing or a pressure. Study in the States identified that 75% of the women who had a full-blown heart attack described unusual fatigue the month before. And this is the type of unusual fatigue where you have to sit down when you're making the bed. There's shortness of breath, which is a common symptom. The most interesting thing, I'm going to go back to these. The most interesting thing about these is that women will not have just the chest pain. And a man will come in and say, I've got this incredible chest pain, elephant sitting on my chest, and we know it's a heart attack. The women will present with some kind of pressure, but they will report 2 or 3 of these other symptoms that kind of don't make sense to the clinician. They say, but I've been feeling really sick, and I thought I had the flu, and I'm really short of breath, but I'm out of shape. And so women start to describe it, and that's where it gets confusing. This book that we read in our book club called The Dictionary of Lost Words is called historical fiction, and it's about women. The Oxford English Dictionary, the creation of the Oxford English Dictionary, and it talks about the idea that in the creation of the Oxford English Dictionary, any words that were related to women or females used were kept out of that dictionary. And so we've grown up in a society in the English language where women use different words, and they describe their chest pain as pressure or tightness. And I was talking to an ER nurse that identified that if you don't use the word chest pain, the word pain, then you don't go into the chest pain protocol. The other thing that just absolutely blows my mind is that women are more often the pain arises when they're resting or when they're asleep. And again, Shannon Scott at our gala talked about this. She woke up in the middle of the night with this incredible chest pain. And the thing that clinicians are taught is to ask, what were you doing when the symptom happened, when the chest pain started, and people would be shoveling or running. But if you say, well, I was asleep, and they're thinking, well, then it can't be heart disease. Mental stress triggers these symptoms, and women tend to show up in the ER after. They downplay their symptoms. And so these are the other symptoms that women will talk about: nausea, excessive sweating, back and shoulder, right arm pain, trouble sleeping, jaw pain. Palpitations is a common symptom where your heart is racing. But guess what? All of these are also related to perimenopause. Women absolutely say they have palpitations, or they have back and shoulder, and now a big thing is frozen shoulder is becoming more common as a symptom of perimenopause. Abnormal excessive sweating, those are the hot flashes. So we have to know our bodies, and we have to say, I think it's my heart, or start to pay attention to what's going on with your estrogen levels. So what are the take-home messages here? Estrogen just doesn't affect reproduction. It protects your blood vessels, the heart, and your brain. Women's heart disease is different, and we're only now fully understanding how hormones actually shape that risk. We really need to rethink what's normal for women and women's heart health. Early periods, heavy periods, erratic cycles, amenorrhea are not normal. And we need to start paying attention to that. Vascular symptoms, which are hot flashes and night sweats, they're not normal. And actually, women who presented with these overt vascular symptoms, who really had early and strong hot flashes and night sweats, already have indices of, it's called subclinical cardiovascular disease. So they have poor endothelial function, poor flow-mediated dilation, so the vessels aren't opening and closing properly, and greater aortic calcification and intima media thickness. They already have those signs and symptoms. So there is a movement now for sure in the perimenopause and the menopause literature that estrogen is actually maybe going to prevent women from getting heart disease. High chronic stress levels are not normal. Not sleeping is not normal. And I was driving listening to a wonderful book called Why We Sleep by a neuroscientist. And he said that there is an association that's been developed between sleep deprivation and dementia. And 2/3 of people who have dementia are women. So I think it might have something to do with the fact that all these women that have said, I just am not sleeping, or maybe I get 4 hours a night as they're going through perimenopause, it's causing damage to your brain. And I identified what estrogen does for your brain. Questions related to your heart health, we need to know, what is your female specific reproductive history? The only question we ask women now is, when was your last period? And we need to be asking, when did you get your period? What was it like when you were younger? Did you have times when you didn't have a period at all? How long did that last? Also, on a scale of 1 to 10, what is your stress level? That was the key indicator of our gender index that we created, that identified that if you scored high, you were 4 times as likely to come back with a second heart attack. What reproductive stage are you in? Women need to know that. You need to be thinking about, well, where am I at? And am I having this brain fog because my estrogen has started to go down? This is our research website, and I'm just so proud of it, just because so many people have contributed to it, and where women's health matters. And I was so fortunate to get the Kabat-Zinn chair, because it enabled me to start thinking about this as far as women's heart disease is concerned. And I would never have gotten into it. And I was getting so discouraged because, I'd been at it for 5 years and nothing was changing. And that's because we weren't looking at estrogen before. And now, because of this big movement in perimenopause, we are now making the connections. And we have a registry where we ask all the questions that we need to ask, so that we can start asking women to give us that data, so we can turn around and say, do you know, 40% of these women are reporting that they had vascular complications of pregnancy, which we know could be related to estrogen deprivation. So it's starting to we're starting to really make inroads in collecting the data and doing studies. And we have all our studies listed on there. And as I said, every time we open a new study, we are overwhelmed with people who help to participate. And this is the other thing that was mentioned, that in the introduction, we have now opened our Cycles to Cessation. It's a virtual online clinic for women 40 to, I think it's 55. It could be lower than that. And we have virtual visits, and it's nurse practitioner led, and you get it's part of the primary care system. And we've been given the money from the government to we identified that there are 300,000 women in Alberta in that age group who don't have a family physician. And also that it's a need. Women need to understand this, and they need to start have this discussion with somebody. Where are you at? What are your plans? Where are we going? And you can request an appointment. We opened it, I think 2 weeks ago now, and we've been overwhelmed with people already. And I'm trying to find funding to get some more NPs in there, because there's clearly a need, and we're changing things. The other thing that we have introduced, I don't think it's here yet, a slide on, but we are creating an online app that's called Awareness and Understanding of Reproductive Aging. And it's a really fun app, and we had women in this age group that have been helping us build it. And we have all this information, and we have the evidence, and we put up resources, and it's going to be available probably in April for anyone that wants to go on and look at what's going on with their bodies. And we have all sorts of ways to look at stress and physical activities. And we talk about diet and nutrition, and it's going to be wonderful. And again, because of the generosity of the people that are funding us to do this research. And having said that, I need to thank the Alberta Women's Health Foundation, WICRI, University of Alberta, of course, the Lois Hole Hospital for Women and the Lois Hole Hospital for Women's Society, the CK Huey Heart Center, and the Royal Alec Hospital Foundation, who have all been absolutely incredible in moving this along. Thank you so much.
Thanks, Colleen. I always learn something new every time I hear you speak, and thank you for sharing your expertise with our community. It's so valuable, and we're so lucky to have you. I'm going to facilitate the question and answer portion of this evening. And there's definitely a theme, Colleen, with questions, quite a few questions specifically about the use of hormone therapy post menopause. So we're looking at age ranges, people putting in the chat and the Q&A here, over 65, 73, like these kinds of stages. And some of the specific questions relate to, if at that point you have no estrogen on board, is there anything you can do to influence your heart health if you're not having ongoing hormonal or vasomotor symptoms?
Yeah, so this is really an interesting discussion because that's what's happening in all of the states right now. And the discussion is, if you do not have it comorbidities, if you don't have other things going on, then you can start estrogen at any age. I mean, the rule that the guidelines say is 10 years after your menopause, or under 60 years of age. However, those were based on the Women's Health Initiative, and it wasn't appropriately run. And there were all sorts of errors with it. So it is a discussion you can have. There's a clinician in the States says, you're never too old. You need to ask if you can go on estrogen. And one thing that I have learned that I wish I'd known before my poor mom passed away is that it's pretty basic now that we're saying every woman 60 plus should be on vaginal estrogen of some kind, because your tissues in your perineal area have estrogen receptors. And what happens is the tissues start to get thin and dry without feeding them with estrogen, to be honest. And it's absolutely now used as a way to prevent UTIs, urinary tract infections, because your tissues aren't strong enough to fight off that bacteria and you get these UTIs. And I say with my mom, because, she was quite a bit older when she got it, in her 90s, but the first one, she got crazy delirium. I'll never forget. I went over to see her and she said, "Did you know the internet is controlling my television?" And I thought, what? And, she had significant delirium, and we cleared that up, but then she got another one and another one and another one. And I just think every woman should be on either a cream or a gel or the insertable estrogen post 60. I really do, because your body is not producing enough estrogen. We're just living way, 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 way longer than we used to.
Yeah, our lifespan is much longer, and so the time that we're spending without hormones is so much more significant when you look at it that way.
Yeah.
There is a question specifically about Vagifem or vaginal estrogen. Does that give us any heart or cardiovascular protection?
Absolutely not. Thank you for that question. And Brianna wouldn't know this answer to herself. And I'm sure you're prescribing it, but no, that's why I was saying vaginal estrogen, because it stays down there. It doesn't go systemic. Although, I have heard the odd person that said, the minute I started it, I had headaches or something like that. But in theory, it doesn't go into your bloodstream because it's absorbed in your perineum and your tissues.
So it's a very local effect. It's very beneficial for
and
that.
yeah. And we're getting so much better at dosing too, Brianna, right? Like it's the creams and the lotions where you can put a dosage in there, in the sense that I remember originally the VagFem was one dose fits all, and that didn't make sense to me because we're all so different. But that's really changed and really advanced.
Yeah, yeah, absolutely. And that's a great segue into a question about research as far as like route of administration. Like, do we have any evidence that suggests that, you know, a topical estrogen, and now we're talking systemic, right? So we have topical estrogen that's for your vulva, or tablets that get inserted into the vagina, or cream that gets inserted into the vagina. And then we have like our systemic estrogen that may be either transdermal, whether it's a patch or a cream, or we have oral estrogens. And are you aware of any like evidence that says one is better than another as far as the heart goes, cardiovascular system? That was a question that showed up here.
Yeah, not as far as the cardiovascular system is. There's a fair amount of literature that says the patch, because it doesn't go through your liver to be absorbed, that the patch is better to start off with. You know, if that's it, rather than the pill, an oral pill. Because then you can see if it gets rid of the symptoms. And the other thing is, we should mention is that estrogen has it's on the docket for if you have vasomotor symptoms, if you have hot flashes and night sweats, but it is being used very effectively for other symptoms like brain fog and anxiety and those others. So someone might suggest, oh, you can't have it because you don't have symptoms. And speaking of that, back to the other question, there's leading physicians in the States that say, if you want to stay on it as long as you want. There's nothing to identify that it's harming you to stay on it, to stay on estrogen. And some people want to go off it because they say, well, I'm not having the hot flashes anymore. And then the hot flashes come back, so they go back on it, right? Because those hot flashes can continue like at 10 years after menopause even. So I was mentioning this to you before, Brianna, that one of my colleagues in Toronto really made a really interesting point to me that, you know, women at 16, 17, or whenever you started, don't think twice about taking estrogen, progesterone as a birth control pill. You are taking estrogen and progesterone in those pills, or however you use for your birth control. And it's controlling your brain not to do follicle stimulating hormone. But the interesting thing is now we say to perimenopausal or post menopausal transition women, oh, it's bad for you and you shouldn't be taking it. But you've been taking it probably for 10 years anyways. We've just got to change the way we're framing it. I really do think that it's something that will almost become like, you know, something that women will start to take, you know. Also because the new dosages are so small and can be adjusted. And that wasn't the case with the original Women's Health Initiative. And it was horse equine urine made the estrogen. Now we have what they call biosynthetic, exactly the same as the estrogen that your body makes.
And I just want to clarify because a whole bunch of the chat like lit up when I was like, okay, we've got vaginal estrogen and then we've got systemic estrogen, and people are like, wait, vaginal estrogen helps your heart? And we're like, no, that's what we said. So vaginal estrogen doesn't have a systemic effect. It's just local. It's affecting your vulva and your vagina, and that's it. Once you go to those oral estrogens or transdermal estrogens, that could be the patch or the cream that's going elsewhere on your body, it's a different dosage, and that is systemic. And those are the things that are going to impact your heart health.
And brain health. Yes.
And brain health. Yeah.
The mental health issues, right? Like, yeah.
Anxiety, depression, brain fog, all of that. Yeah. Yeah, there was an interesting question in here about AFib specifically. Do you know of any connection between like estrogen withdrawal and AFib?
I have not heard that. You know what it might be confused with is that estrogen, lots of women talk, perimenopausal women talk about palpitations. which might be confused with atrial fibrillation, maybe.
Right.
But the fast heart. But
Right.
yeah. But
Yeah.
I haven't heard about AFib.
Okay. And then a couple questions about like advocating for heart testing. So figuring out like depending on age and stage, like what language would you use to uh to advocate for preventive testing? Like, are we looking at cardiac stress tests? Are we looking at, like you mentioned earlier, angiogram? Like, folks want to understand more about how to understand their heart health
Yeah.
or their
And
risk.
if it's such a good question, and we aren't there yet.
Mhm.
As I mentioned at the gala, there's a test that can be done that's done along with your angiogram for women, well, and men, if they think it might be microvascular disease or coronary vasospasm. And after you have your coronary arteries checked in an angiogram, then they inject different drugs that cause your vessels to constrict. And if your coronary artery doesn't constrict, but you say there's the chest pain, we know that it's probably the microvasculature underneath. And I think there are right now in Canada 4 places that do that. Until recently, the Mazankowski does it now, and there's a large waiting list. And until the Mazankowski got it, women in Alberta were going to Vancouver to get it done. Those that could pay for it and could get themselves there. But it is a definitive test. But I was it was called the ANOCA International Conference when I was at the European Cardiovascular Congress, and I went to the ANOCA conference, and it was a really, really interesting discussion about testing, and specifically for women, because this test is called provocative testing, and it looks at how your vessels work rather than whether there's a plaque in there. And at the meeting, Japan raised its hand. And they said, "Oh, they have 300 centers that do this testing," which everyone in the room kind of went, "Oh my gosh!" But they are consistently testing everyone who comes in when the angiogram shows that they have clear coronary arteries, and they're still having this chest pain or angina. But then there was a discussion because Australia has like 3, and they said that they are starting to. We know what works for those conditions, so they're doing a thing called clinical diagnosis. So we know that beta blockers, and I'm forgetting the second one. I'm sorry, Brianna, that work. There's 2 drugs that work. One works for vasospasm, and one works calcium channel blockers, and one works for spasms, and one works for microvascular disease. And what they've been doing in Australia is while they wait on the wait list for the test, they'll trial them on one of those 2 drugs. And if the pain goes away, they don't even need the test, and they could still have it, and I thought that's what we need to do here. So that's what our new NP clinic is looking at is, are we able to do that for people that are on the wait list? And can we say we've ruled out it's nothing else? They've all had a coronary angiogram to say it's not your coronary arteries. Let's figure it out. But we also are collecting the data to say, I was an athlete, so I didn't have my period for 4 years. So then you think, aha, something's going on there.
Totally. Yeah. So it's there's like a very like holistic look at all of those factors. Like your menstrual history has become so much more important in understanding like your future well-being from a cardiovascular standpoint. A few questions specifically about blood clots. So the influence of estrogen on blood clot risk. Can you speak to that?
So the specialist or expert in the States had a really good session on this that I was listening to. And they're on podcasts. One of them is Mary Claire Haver, Haver, and Heather Hirsch, Hirsch. And they have podcasts and they have Instagram, and they talk about this constantly and really answer all these questions as well. And she was saying that it has to be some kind of that you have something in your system that's causing blood clots. It's not that the estrogen will cause the blood clot, but if you have something, then no, you should not. Like if you have some kind of clotting disease, or you should not go on estrogen. But there is there is no evidence, there is not sufficient evidence at all to suggest that estrogen would cause a clot. And
Hmm.
honestly, when you think about it, in another incredible book is called Estrogen Matters.
Hmm.
And it goes through all of this information. But one of the things he says is if estrogen caused clots, then we'd all be clotting from 13 on, right?
Right.
Like it doesn't make sense to say suddenly if we give you what you've always had in your body that you're going to get clots.
Hmm. Yeah. Yeah. So, and I think that like kind of speaks to that like risk benefit discussion that everybody
Yes.
needs to have on a one-on-one level. Along those lines, there are some more questions specifically about migraine and contraindications for estrogen. Now, I also have like a fun personal curiosity. Do you know of any like link between migraine and cardiovascular disease? You know, there are some like vascular theories around migraine and things like that. But when we look at estrogen and its contraindication in patients with migraine with aura, there's three or four questions about along those lines here, and also stroke risk and estrogen.
Yeah. I have to say I'm not up on the migraine literature. I've seen podcasts that suggest that it is a vascular event, and we're just
Mm.
talking about migraines, not migraines with aura, which apparently are quite separate.
Hmm.
And saying that it is the estrogen receptors not getting it, and they're clamping down, and you're
Hmm.
getting these vascular headaches.
Hmm.
So in my simple mind, I would say then estrogen would help, right?
Yeah.
And the stroke risk, again, I haven't seen it.
Hmm.
The evidence for it, and um, the elephant in the room is always breast cancer. And if you've had prior cardiovascular events, they'll say you absolutely cannot be on any kind of estrogen or progesterone. And this was a result of the Women's Health Initiative. And
Hmm.
actually, that if anyone reads the book Estrogen Matters, you can see that they absolutely debunk that. And the idea that you really do need to have that discussion with whoever your practitioner is. Um,
Hmm.
it isn't a rule. And interestingly, Brianna, when I was looking, I wanted to say, I was trying to think of the mechanistic, what's going on. I guess they're assuming that if you've had a myocardial infarction, that you have some kind of plaque buildup. And
Hmm.
so, estrogen might not help or it might hinder that and make it worse if you've had a myocardial infarction. But that's only if it's a plaque buildup. And I've identified that that's not the kind
Hmm.
of heart disease that women have.
Hmm.
So I think you can't just say if you've had a myocardial infarction, you could have had one that has no occluded vessels, the
Hmm.
NOCA, then maybe you'd be a great candidate for your heart and keeping your vessels pliable. And one of the things we do know, but one of the things you asked it earlier about measurements, one of the things we've been doing studies with is called arterial stiffness. So over and above blood pressure, we have measures, you can do this measure that's non-invasive of arterial stiffness. And it measures the flow of blood and tells us if there's a range. And so based on your age, what your arterial stiffness can be. And the interesting thing about that, it takes over an hour to do this.
Hmm.
And that's just not clinically viable. And
Hmm.
so, it just makes me smile because it's the one measure that women really need to see what's
Hmm.
going on in their vessels. And it takes an hour. So there's a new machine out that says it replicates what the old one does. So we're going to do a test to measure them both. So then we can say, okay, we got the little one and it'll do great.
Yeah.
We need to move this forward so women know, if you're 30 and you have arterial stiffness of what we would say is a 60-year-old, something's going on in there. And we
Yeah.
need to prevent it from, like, we need to give, I keep thinking of estrogen, bathing your cells in estrogen so that you get that pliability again, right? Like it is reversible. Like there are studies that have reversed arterial stiffness. So we know that. So let's do something about it.
Yeah. Yeah. And I think so it again, it goes back to that like risk benefit analysis for each individual. Like we want to give people as much information that serves everyone, but then there's all these like individualized and nuanced
Yes.
conversations. And
Yes.
I mean, like I want my arterial stiffness measured.
Yeah.
And let's put a plug for the research database. So how do people, because that was a question, is how do people get onto the database? Not the clinic, we can talk about that in a sec, but the database.
Yeah,
Is that
so the database is on, if you, the first website, which is www.womensresearch.ca.
yeah,
On that slide, even it says at the bottom, registry. And
right.
you just hit there and then it'll ask you the questions. And we need everyone to be filling it out.
Yeah.
It takes probably 20 minutes.
Like even probably faster than maybe I just know my personal history. I'm like,
Yeah.
yes, no. But that it is so helpful to get registered. Okay, somebody has put it in the chat. Thank you so much to Lynn. So it's yegwomensresearch.ca. And that's how you can become part of the registry. And then I do want to circle back though to risk benefit discussion.
Yeah.
Just because breast cancer comes up over and over and over again in the chat, people with a personal history of breast cancer or people who are on things like tamoxifen for a time. What would you say to those folks about their heart health and the potential role of estrogen?
And there's still lots of discussion going on, but there are cohorts in the States of women survivors of breast cancer and breast cancer treatments who are on estrogen because they've chosen to do that. They've had that discussion with their physician, and like one of my friends said, I'd rather have breast cancer again than be suffering the way I'm suffering because of the hot flashes and night sweats. So there that we are getting data from those cohorts. But having said that, in the book Estrogen Matters, the scientist says, if estrogen causes breast cancer, then every woman who was in menopause with no more estrogen flowing would be safe from breast cancer. But that's when we really see an increased risk is postmenopause in numbers of breast cancers. And we've always said, it increases with age. So that makes sense too. So it's just fascinating to me that we're basing it all on data that wasn't good data in the first place. And we scared every woman off. Like, it's unbelievable to see that it says my internet connection is unstable. Sorry, but it's unbelievable for me to see when you see that, 40% of women were on estrogen and progesterones. And then this study, they presented their evidence to the press before they went to peer review, which is just unheard of in the scientific committee. And they said it to the press, and that dropped down to like 2% in the United States, and it actually, in my mind, we did damage. And I wrote a column in the Edmonton Journal and said, now we've asked women to wait till you get heart disease and wait till you get osteoporosis and wait till you get mental health or cognitive issues. And that's unacceptable, right? Like,
Totally.
Yeah.
When we could potentially have an impact on reducing risk earlier in life with different interventions, right? Yeah, there's a really neat, like, kind of specific case example that speaks a little bit more to like the perimenopause or like late reproductive phase. So this particular individual mentioned that they're a 38-year-old and been put on topical estrogen and oral progesterone already, but also genetically predisposed to heart issues and have had that elevated LP little a tested, and mom had a heart attack in their 60s. So I know we're not giving personal advice, but I think like I like this example because it's talking about risk of heart disease and then talking about being in that sort of late reproductive phase, early perimenopause. Should that be a situation where we're considering something like estrogen for prevention?
Yeah, and you know what? It's so interesting to me because in the old days, and even today, if you were to go into someone, they would pull the Framingham or whatever
Right.
they're looking at. and say, well, you're not a drinker and you're not a smoker and blood pressure isn't high, you're only 38, and they'd say you're low risk.
Hmm.
But that's not what our risk factors are, because none of us are sitting there being, we've all, we've all, people have quit smoking, and we recognize about alcohol, and we're trying to eat the right things. And that is not the picture of the women that we're seeing in clinical settings, that have heart disease. These are healthy women that are fit, and, something else is going on. And so our risk calculators are looking at something else in the first place.
Hmm.
So,
You're right.
and so we need the evidence to sort of say, well, if you had complications of pregnancy and you had this, those are related. Like the complications of pregnancy, which are the vascular ones, are hypertension or high blood pressure in pregnancy, gestational diabetes, and then the preeclampsia or eclampsia. Those things are related to your heart and your vascular system. And we do know if you had those, you will show up with heart disease 10 years earlier than anyone else. So
Right.
those are the sort of things we need to collect. So that's why you have to sit down and have a conversation with this person, and can't, not this rule that if your mother had a heart attack, then you can't go on estrogen. That's just not good enough anymore, right?
Hmm. Yeah. Yeah. Absolutely. And I think so there's a lot of questions about accessing hormone therapy.
Yeah.
And so a lot of people with questions about, well, where can I get my hormones tested? Can my regular doctor prescribe this? Can my regular doctor test me? Where can I access this care? And there's, lots of feedback from folks that have said, well, my family doctor doesn't want to have the conversation about estrogen, or says no, it's not even a
Yeah.
conversation, right? And so how can we help people understand how they can access this care, and how they can advocate for this care when they might have a provider who's hesitant or resistant?
Yeah, so that's why we started the clinic, that we started. And it's a nurse practitioner led, and it's publicly funded. And we got the money through Primary Care Alberta, because I don't think it's fair to women in Alberta, that to get this kind of care, you have to pay, and you have to pay handsomely for it.
Hmm.
That's a real inequity. So part of it is political action to say we need it as women. And as I said, we filled up right away, and we only have, one FTE, nurse practitioner. So we've got to find funds, because I really want this to succeed.
Yeah.
Part of it is knowing what you want, and I know it's tough when a doctor says I can't discuss it, but you say, what, go on our website once in April, because it has all this information. And I talk about the cardiovascular, and we have someone talks about the brain health, and Granny, you talk about supplements and different things. Like it's
Yeah.
everything that women are asking here. And it's I'm sorry, it's a bad answer, because right now you still will have physicians that say I won't do it, but we are
Hmm.
working so hard to move that into mainstream for women's care. And the one thing we cannot do is separate it out, saying, well, we're all these women are coming for estrogen. No, 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 they're coming for women's health. They're coming for their
Yeah.
heart health and their brain health, right? Like, we've got to get away from separating our bodies that way, because we don't work that way.
Yeah, I usually people are coming for help with a given like issue or symptom, not like demanding hormone therapy. Maybe
Yeah,
they've found out that hormone therapy can help with a lot of those symptoms, but
yeah.
I just want to repeat the website address. It's cycles2cessation.ca. And at the very top of the website, there is a link that you can go and get yourself on the wait list, and you'll be contacted by the clinic. It's purely online, right, Colleen?
Yes, virgin. And so that's the other issue, that if you have other things, like you have blood pressure that's kind of up and down, we can't take your blood pressure. It's virtual.
Hmm.
So, it's there's a screening process, and it asks a
Yeah.
bunch of questions first. So
Yeah. And that is funded right now by Primary Care Alberta. And so we're part You talk about that.
Well, no, we got money.
Yeah.
Great and very grateful from Primary Care Alberta to start this, and especially the NP-led portion, nurse practitioners, because they can do this and do it really well. And it's a great way for our healthcare system to adapt, and it's efficacious to be doing it this way. So we've got to we've got to put out the stats and show that this is really a good thing.
A good model. Yeah.
Good
So it's
model.
research. We're doing research and practice all at once, which is super cool. I tried to put the link in the chat. There's people asking for the link. For some reason, when I post in the chat, it is only going to host and panelists. So maybe somebody who is on the back end of the webinar can help me with that and post that link in the chat for everyone. But also, this recording is always up on our YouTube channel within days of this presentation. So you'll be able to see the actual slide that Colleen had up there with the cycles to cessation.ca website. The other thing that you mentioned that I want to make sure everybody hears again is the Aura app. And so that isn't quite ready yet. But if you do follow along with Dr. Norris and Alberta Women's Health Foundation and all of these resources, like we all like to share each other's work because it's so important, because that's how everybody learns and grows. And so
Yeah.
you will hear about it when it's live. Don't
And the YEG Women's Research, we will put it up there at the minute it goes live. Yeah.
Amazing. So people will be able to find it. And I know that there are a lot of questions that we didn't get to, and that's always the way with these hot topics. That was a hot flash pun in case you didn't catch it. I practiced that one. But yeah, we're sorry we didn't get to everyone's questions. We do have like we get the questions stored in Zoom webinar, so we are able to try and answer some of those in email newsletters and stuff like that. So make sure you subscribe and follow along with the Lewis Hole Hospital Women's Society. And if you enjoyed this between us, we would love for you to consider becoming a monthly supporter. If you're curious about joining the Women's Society, please go ahead and reach out. You can access us in your inbox when we send our follow-up emails, and we will be sending that follow-up survey like Ijoma mentioned. And that survey, it gives us, we actually like action everything that you put in there. So, or we do our best, right? So if you have feedback, we're very grateful to receive it. I just want to sincerely thank you, Colleen, for being part of tonight's event. And of course, huge thank you over to Alberta Blue Cross as our presenting sponsor. And I will pass it over to Ijoma.
I wanted to extend a very special thanks to those of you who have donated already during your Between Us registration, and to the individuals and businesses who support us monthly and continue to be active supporters of the Lewis Hole Hospital Women's Society. This webinar is not possible, without your support. So thank you so much. Last but certainly not least, a heartfelt thank you to our presenting sponsor, Alberta Blue Cross. Again, we're so grateful to have your support and be able to partner and put Between Us series on. It really makes all the difference. Keep an eye out for the feedback survey that I mentioned earlier, coming your way soon. Complete it and enter it for that $25 gift card, courtesy of Alberta Blue Cross. The winner will be contacted directly. Thank you for joining us, everyone, and we look forward to seeing you next month as we chat about the link between pelvic physiotherapy and endometriosis. Have a wonderful evening and a fantastic heart month.